Good afternoon, all. We'll be starting shortly. So, very good afternoon, all of you. Welcome to the first, yeah, welcome to the first IV Talks session. I am Pooja Swarup Saxena from Polymed. Along with me, I have my colleagues, Ms. Ipshita and Mr. Shinoj. As you all know, this chapter is hosted by INS India Pune chapter. And one more very important thing, that this is an exclusive platform only for INS India members. So once again, thank you very much for joining in, taking in time for increasing our knowledge in the safe infusion therapy areas. And without much further delay, let me invite President INS India, Colonel Binu Sharma, ma'am, to please officially flag off IV Talks today.
Namaskar, everyone. Thank you, Pooja. It gives me immense pride to be actually part of the first scientific session of IV Talks on the platform of Infusion Nursing Society India. All of you are INS members, and I'm very glad to see many of you in the platform and others joining in one by one. The excitement on learning the technical glitches, the management in neonates, pediatrics, adults, learning about infusion therapy, teaching about infusion therapy to your mentors is the sole vision of the nursing professionals. In today's time, all of us know that infusions are a way of life. In whatever clinical setting a patient will go through some kind of infusion therapy right at the time of entering to the hospital. Hence, Infusion Nursing Society has taken the responsibility to provide guidelines through the INS standard of practice. And also, we've taken this new initiative with our knowledge partner, associate partner, Polymed, to train nurses on very, very specific topics. I'm very pleased that today's topic is dealing with neonates and pediatrics, the central venous access devices management, maintenance, managing complications for neonates and pediatrics. We all know this is a very, very special, vulnerable group of patients in the hospital, and not many of us are very well trained. Let me thank Dr. Gauda Ankul Prasad for coming forward for our first session. He is the HOD of Pediatrics at Sayadri Group of Hospitals, and along with him, we've got a nursing speaker, Miss Neha Dive, speaking on a particular case. So I think you got an exciting 1 hour. Very deliberately, we have kept it just 1 hour, which will deal with the scientific session. We'll have a online quiz, very exciting. We will also have time for Q&A within the 1 hour. So friends, make the best use of it. Every month you will see a very, very niche topic as Ivy talks ongoing from now onwards. And congratulations, Ms. Arya Kulkarni. She is a chapter co-chair for Pune, and Tripti happens to be the chair. I'm not very sure if Tripti is in the session. Thank you, Arya. Congratulations and well done for taking the lead. Over to you, Pooja.
Thank you, ma'am. And I would like to call upon Arya ma'am now to take the session forward. Arya ma'am, and just a little bit of introduction about ma'am. I would like to share that ma'am is the corporate nursing head with Sayadri Hospitals, Pune. Ma'am is having around over 24 years of experience into nursing, and she is an MSc and MBA in hospital administration, co-chair of Pune chapter, and ma'am is a lifetime member of INS India, NE, and TNAI. So with this, I'd like to hand it over to ma'am. Over to you, ma'am.
Thank you, Pooja. And thank you, Vinu ma'am, for giving us the opportunity, the Pune chapter. And on behalf of Pune chapter, I thank the this joint venture of Ivy Talks, which is venture is with the Polymed. And I'm very much excited, and we are very much thrilled to launch this because we are kickstarting it. So I got the privilege to, from the Pune chapter, from each one of you, to thank Vinu ma'am and Polymed. Thank you, each one of you. And I would like to know if you are happy to share, then please type H in your chat box so that we should know that yes, everyone is happy to join today with us for the Ivy Talks. Yes, Pooja, you can just see that how many of them are typing H in their chat box. So quickly, please type H. H. Yes, yes, motivated, motivated. Yes,
Super.
so this H is really giving me so much motivation to go through now because kick-starting without your appreciation, we are nothing. So let us start with this CVAD care in neonate and pediatrics, which I'm very much sure, like me, Binu madam said, it's a vulnerable group, and we are here to talk about that because when I was searching in statistics, over 5 million CVADs are inserted, and this study is not of India, it is of US, of course. But how many complications? This is 31.1 complications percentage, 31.1 percentage. It is too much. So let's talk on this, learn this, and knowledge sharing is what we should have for this very, very essential topic for today. That is CVAD care in neonates and pediatric. Right. With this, I will introduce my speakers for today, who is Neha Dive and Dr. Anukul Gowda. So Neha Dive will be talking about the scenario she will give, and then the expert will be speaking on it. So Neha Dive is working with me with Sayadri Group as a corporate nursing education manager. She's an experienced cardiac OT nurse, sister in charge, nurse educator with over 14 years of experience, and she's currently associated with us, and she's fabulously looking into the training and education of Sahyadri Pan Sahyadri Group. So here I am with her, and I will be giving her the mic to uh, for uh, for giving the introduction with the scenario. I would just quickly introduce the Gavda sir also. So the next slide is for our consultant and speaker for the main speaker for today, who within one say he has accepted our invitation to be a speaker. He is our senior consultant, HOD, Pediatrics and Neonates in Sahyadri Group of Hospital, which has started newly in Shivaji Nagar unit. He is experienced one. He completed his MBBS, MD Peds from Assam Medical College, and he has pursued Doctor of National Board of Neonatology, that is DNB, in neonatology from KEM Pune. Over 12 years of experience in managing pediatric and newborn, and 7 years in managing NICU. His main interest includes the perinatology, neonatal hemodynamics, functional echo, clinical research and publication, advanced assisted ventilatory support, care of preterm, which is he has a specialty in. He's very, very skillful in performing the procedures needed in NICU, and he saved so many premature and low birth weight babies also. He has several publications to his name, and he is also acting as a viewer for journals. So here I'm welcoming Gavda sir and Neha. I will be handing over the mic to Neha so that she can go through the scenario, and maybe within 2 minutes sir also will join. He is into one short, just 5 minutes. He's just in seeing the last patient. So he will see that he's joining just after that. So here I will hand over and welcoming each and every one of you, and thank you for that H. Please type your city name also, so we'll be glad to know from where you have joined us. Right, Pooja? So thank you,
Of course.
Binu madam, and thank you, Polymed, for giving us the chance. Let's hear from Neha the scenario.
Hello, good afternoon, one and all. Pooja, am I audible?
Yes, Neha, very loud. Yeah.
Yes, good afternoon, one and all. Thank you, Arya ma'am, for the beautiful introduction and to guide us on the importance of IV talk today. Uh, Before moving on to the case scenario, I would firstly like to thank and sincerely appreciate Arya ma'am, DGM Sayadri Group of Hospitals, and Colonel Binu Sharma ma'am, President of INS India, for providing this wonderful opportunity. Thank you so much, Binu ma'am. I would also like to thank Pooja and Ramesh from Polymed. It was a wonderful experience coordinating with both of you all. Thank you, Pooja and Ramesh and the entire Polymed team for this. Let's move on to the case scenario now. Um, a 30-minute-old baby with gestational age of 26 weeks, extremely preterm, with a birth weight of 900 grams, is delivered in an emergency cesarean section due to maternal severe preeclampsia and fetal distress, having an Apgar score 5 at 1 minute, 7 at 5 minute. The medical history suggests respiratory distress syndrome, that is RDS, requiring surfactant and mechanical ventilation. The neonate is hypotensive and hypoglycemic, requiring urgent IV access for fluid and glucose. Difficult peripheral IV access due to extreme prematurity and fragile veins. So this is the case scenario that I want to present today. As it has already been displayed, we can once again go through the case scenario. A neonate has been born a couple of minutes ago, that is 30 minutes ago, with a gestational age of only 26 weeks. The neonate is extremely preterm we have already gone through the age that is 26 weeks. So the neonate is preterm and the birth weight is only 900 grams. The neonate was been delivered to the mother, okay, who has an history of preeclampsia and a fetal distress. The Apgar score is 5 at 1 minute and 7 at 5 minutes. The medical history suggests respiratory distress syndrome, that is RDS, and due to the fragile veins and poor peripheral IV access, okay, the team has now they have taken a decision to have an UVC line. UVC is a umbilical venous catheter, and they have now indicated to go for a UVC line. Let us discuss the other indications for the UVC line. These indications are administration of IV fluids, medications, and other parenteral nutrition for a child. Exchange transfusion, this is one of the indication for the UVC line. Central venous pressure monitoring. Next is emergency access for resuscitation. As we have seen, the child seems to be a little critical. Next is umbilical venous catheter is mostly used for the fluid administration, and the umbilical catheter is used for blood pressure monitoring. Uh, so these are certain indications for the UVC placements. It is umbilical venous catheter placements. Um, Sir will be guiding us on the definition, the indications, purposes, management, the nursing management, as well as the medical management for this child. So before going on to this, I would also in short brief you all regarding what is a nursing management. Okay, so I have divided the nursing management into pre-insertion nursing care, uh, post-insertion nursing care, and the actual maintenance and care for the UVC line. So the pre-insertion care, I would rather suggest that the assist in the catheter insertion, because as it is a very small child, there are chances of infection. So this plays a very important role. For this, we have to ensure that aseptic technique is been used or are been followed. Monitor neonate's vital signs, that is heart rate, his respiratory rate, and the oxygen saturation, which again plays a very important role. The next pre-insertion nursing care includes educate parents about the procedure and the potential risks, because taking a concern also plays a very important role in it, because the as a baby neonate is critical. We have informed the parents, we have health educated the parents on the UVC line insertion. The next is there are other CAVDs also, like we do have syphilis vein insertion. We also have a PICC line insertion. Uh, but in neonates, the UVC line plays a very important role. The post-insertion monitoring mostly includes check the catheter site every hour for the site of infections, leakages, or displacements. Monitor the circulation, capillary refill, limb movement. Observe for signs of complications, because the child might go into the respiratory complications like cyanosis, swelling, and poor tissue perfusion. The next care involves assess for the complications like bleeding, malposition, extravasation, monitor the blood pressure and the glucose levels. The maintenance and care of the UVC line further will be dealt with Dr. Anukul sir. Pooja, I request you to kindly just give me 2 minutes so I can shift from one location to another. Sir is already available. So I'll hand over the further session and forum to sir.
Sure, sure, sure.
Yes, Pooja.
Right. So Dr. Anukul is joining us. There. So these are small glitches that we cannot avoid during a virtual connect. And especially during a busy day. Thank you all for having the patience. So in the meantime, we can, if there is time, we can have a small Q&A, question answer, or a small quiz. We can start it in the middle as well. Ipshita, you there?
Yes, ma'am.
Yeah. So maybe a quick question from your side will set it up for the IV, for the central way access discussion.
Yeah, like I will start with the small questions.
Yes.
Before that, I will share the questions with the audience.
Yes.
So, questions for the audience. So, is there any major difference between the adult and neonate insertion checklist? So, what do you think for that? Is there any major difference for the insertion checklist in adult and neonates?
You can. Yeah, your voice is little breaking, Ipshita. There is little bit voice breaking over there.
Hello, am I audible?
Yeah, now you're clear. So you can share the screen, the question on the screen.
Okay, so I'll just share the question. Sure. Is my screen visible to all?
Yes, you can put it on the full screen mode.
Yes.
Yes, so let's move on to the first question quickly. Yeah.
Yes. So, which of the following is the most common site for PICC line placement in neonates? There are 4 options, so you can choose the right answer and drop down the answer in the comment box.
Yes.
Internal jugular vein, basilic vein, umbilical vein, or radial artery. So you can drop down the right answer in the comment box.
So Shinoj, you can keep an eye on the in the chat box for the answers.
Sure.
Which of the following is the most common site for PICC line placement in neonates? There are 4 options, so you can drop down the answer in the comment box. Any answers you can write down?
Right, so we're getting a lot of answers.
Yeah.
So
It should you keep some extra time. Don't delay.
Yeah.
Move
So,
to the next question.
yes, you can answer. You can set the right answer now.
Yeah. Obviously the right answer is which one? Which one? Somebody is saying umbilical vein, somebody is saying basilic vein. So which one is the right answer?
Yeah, it's a 50-50 time now. We need to have the correct answer.
Yes. So basilic vein is the right answer for PICC line.
RMM, is it set from your side now? Connection is back?
Yes, Pooja. Yes. Sir has also joined us. So we can continue, Pooja.
Right.
Yes.
Thank you, Ipshita. Thank you so much.
Yeah, I'll just stop sharing.
Yeah, you can stop sharing. So welcome, sir. I'll just put you to spotlight as well. Just a second.
Good afternoon, all. Good afternoon, madam. Thank you, Binu madam, for giving this opportunity to talk about CVD care in neonate and pediatric. And thank you, Polymed, for organizing such a nice talk and important topic. Till now, Arya madam has told and Neha madam has discussed the case. That's Neha.
So do you want me to display the case first?
Yeah.
No, you can start with the slides. Already case has been discussed by Neha madam.
Great.
Discussed.
Right, just give me a minute. I'll just share the slides.
Is the case we have discussed. Neha madam must have told you this is a preterm baby with distress, required ventilatory support in shock. So the baby required inotrop support. So here comes the important critical part. These babies are very small. They need a lot of care. At the same time, we have to take care of their nutrition, management of blood pressure, everything. For this, we need to secure a central line because a lot of things we cannot give through peripheral veins. Like peripheral veins using inotrop can cause extravasation, can cause the discoloration, and the duration of peripheral veins is very less. So it requires multiple pricks, and the number of pricks increases the risk of infection. Where comes the important role of central lines? So what is the central line? Can you roll the slides? The central lines is just a catheter which delivers our fluids or medications directly into some of the larger veins that directly drains into the heart. So it can be single lumen or it can have a multiple lumens depending upon the size we are choosing. So there are different types of central lines like peripherally inserted central catheter, the question we are recently discussed, like PIC line. The other one is the central venous catheter or central inserted central catheter, CVCs, or umbilical lines. There are tunneled CICCs, cuffed CICCs. But in pediatric and neonatal population, the most commonly used one are umbilical venous catheter, central inserted central catheter, CVCs in pediatrics, and peripherally inserted central catheter. That is our PIC line. So coming to the different type of PIC lines, depending upon the size, it can be smaller, less than 2 franc size or more than 2 franc size. Less than small 2 franc size, most commonly used in smaller neonates like preterm neonates, the premicath type. And larger size can be used in full-term neonates or infants. Generally, the preferred veins like saphenous vein, peripheral larger veins are preferred for insertion of this PIC lines. It has a multiple lengths. Like if you are using a less than 2 franc, it's generally 20 centimeter, which most commonly we use in our NI shoes. And for larger babies, surgical babies, we go for that more than 2 franc size, that is generally 25 to 30 centimeter length. No, the saphenous, basilic, and cephalic veins are most commonly used in this thing. The duration, we can keep it for 3 to 4 weeks if there is no other complications. Generally, the minimum flow rate is 1 ml. We don't want to get it clogged because it comes with a smaller caliber. It can develop blood clots. So a continuous infusion should be there. So 1 ml per hour minimum infusion should be there. And depending upon the size, the infusion rate can vary from 9 to 18 ml per hour. The PIC lines are generally not clamped because smaller length clot can happen and it can damage our PIC line. So clamping is not allowed. Sampling we do not prefer because of the thinner caliber. If you are doing sampling, it will cause destruction of the RBCs or breakdown of the RBCs. Blood drugs are not administered through PIC lines. Coming to the other common central vein used in neonates is umbilical venous catheter. Umbilical venous catheter, easy to be used. Emergency, in cases of emergency in delivery room, we can put umbilical venous catheter. The size depends on the gestational age and weight of the baby. Like some preterm babies, we go for a 3.5 franc. If larger babies, we go for 4.5 or 5 franc size. If you are using for umbilical arterial catheter, it can use a smaller one like 3.5 franc catheter. The duration, it can be used for 7 to 14 days, preferably 7 days. Generally for shorter duration, we keep it. After that, if the baby is requiring, then we shift it to a PIC line. Umbilical venous catheter can be used for blood flow transfusion like we use in cases of exchange transfusion. We can do sampling from umbilical venous catheter. If you are using a umbilical arterial catheter, we can use for continuous BP monitoring, ABG, and sampling. So in cases of smaller babies like that case we discussed here, such smaller babies, we prefer to put a umbilical venous catheter and umbilical arterial catheter. Umbilical venous catheter for our TPN and other infusions, and umbilical arterial catheter, so that we can go for a invasive BP monitoring and sampling ABG. So it decreases our number of pricks. In cases of pediatric population, we can use this non-tunneled central venous catheters. These are larger in size, preferably used in case of internal or external jugular vein or femoral vein. Can be kept for 14 days. It also requires a minimum flow, but it can be HAP locked. If you are not using for more than 24 hours, we can keep it heparinized and locked so that it can be used on a later date. The most common indications in cases of newborns or in cases of our NICU. As I'm a neonatologist, I will most commonly I will pronounce of neonates and use in NICU. Most commonly used in preterm babies for TPN or nutrition, total parenteral nutrition now. Your umbilical arterial catheter for invasive blood pressure monitoring and blood sampling. In cases of surgical babies, where we have to keep the baby for 4 to 5 days NBM, it is difficult to manage on peripheral lines. So it is preferred to use a central line. In cases of babies with sepsis, where we have to give prolonged antibiotic, we can use a central line. Hyperbilirubinemia cases where extended transfusion is required, we use a umbilical venous catheter. Similarly, in the first 1-2 days, if the baby is hypoglycemic, we are increasing the glucose infusion rate. As a higher concentration of glucose cannot be used to peripheral lines. Extravasation is the risk there. Higher concentration can cause irritation. That's why in cases of management of hypoglycemia also, sometimes we prefer to use a umbilical line or PICC line. Less commonly in neonates and more commonly in pediatric patients. For chemotherapy, we may use a central venous catheter. Long-term medication is for frequent blood transfusion, patient requiring frequent blood transfusion. And for hemodialysis, we can use a central venous catheter. H, we have already discussed from the starting point. It decreases the number of pricks. It decreases the irritation or extravasation risk. That's why central venous catheter is preferred. The tip is in the central vein, so the site of insertion and the site of delivery is different. So chances of infection also less. Larger veins, if we can use a higher concentration, higher osmolarity medication can be delivered in a larger vein, the irritation will be less and extravasation, skin injury will be less through central venous catheters. Coming to the most important thing, there should be a balance between our procedures and the baby's need. The baby is needing a lot of things, so we are doing an invasive procedure. But the best thing is the less number of invasions, the less number of sepsis and better outcome. To prevent sepsis, we have to follow certain bundles, like the insertion bundle. The most important part in insertion bundle or in any NICU care or prevention of sepsis is hand hygiene. Yeah, we cannot achieve a better NICU or better outcome without proper hand hygiene. So everyone should know about the 5 moments of hand hygiene and the steps of hand hygiene. The most commonly, this is the picture displayed in our NICU, that is hand hygiene. After hand hygiene comes the extra precautions, like for insertion of a PICC line, we will use a gloves. We did hand hygiene, that's why we will not use gloves, or we are using gloves, that's we will not do hand hygiene. That's not possible. In this condition, both are mandatory. Second, then we will go for the skin site preparation, skin disinfection with chlorhexidine gluconate. Earlier, we used to use povidone iodine or betadine solutions, but in cases of preterm babies, it's better to avoid iodine solutions because repeated exposure to iodine can cause hypothyroidism. There are certain studies which show that these babies are in a later date develops hypothyroidism. Placement by a skilled clinician, it is very important to decrease the number of pricks. As we break the skin barrier, the chances of infection increases. All the supplies should be available in before going to the procedure so that you will not touch any other parts or unsterile areas before during the procedure. And documentation on the insertion site is very important. Commonly, when we are taught about PICC line, we follow from periphery to in. You have to wash your hands, put in the gowns, wear the gloves, clean the area, then touch the central part or your insertion part. From periphery to you come to the inner side. Coming to the preparations for our central line insertion, it will be little different for our PICC line and umbilical line. But most of the things are similar, like kidney tray, bowl for keeping our chlorhexidine solutions or sterile water, artery forceps required to hold the umbilical cord, or toothed forceps are required to hold the umbilical cord. Mosquito forceps or dilators. These are used most commonly to dilate the umbilical venous lumen, or most commonly in umbilical arterial, where dilatation is required because it is difficult to insert the catheter in umbilical artery. Needle holder, seizure, blade required to cut the umbilical cord, draft, then or blows, tegadum for fixation. Then comes the syringes. For all these procedures, it's preferable to use a larger bore syringe. Smaller bore syringes or smaller volume syringes like 1 cc, 2 cc, this should be used for sample collection in cases of umbilical wellness, or for heparinization, you can use this thing. Otherwise, a larger bore, 5 ml or 10 ml syringe is preferred. The connectors. And to secure the line, in cases of umbilical catheter, we can use a suture. After our area is prepared, the line is identified, our umbilicus is cut, and we have identified the umbilical vein. Then comes the most important part, how much length to be inserted. For in cases of PICC line, it is measured from the site of insertion. In cases of upper limb, from the site of insertion to sternal angle. In cases of lower limb, from the site of insertion to umbilicus. So that it will be lie in superior vena cava or at the junction, or in cases of lower limb, it will lie in the inferior vena cava, will reach the inferior vena cava. For umbilical catheterization, the easiest formula is shoulder to umbilicus length divided by 2 and the length of the stump. The other methods are there, from birth weight into 3 plus 9 divided by 2. This can also be used. For umbilical arterial catheter, the length should be shoulder to umbilical length plus length of the stump. The trick is measurement of the shoulder to umbilicus length. Shoulder to umbilicus length should not be measured in diagonal way. It should be measured on side in a straight line. The next important thing is fixation. Repeated handling can increase the risk of infection, so the fixation should be proper. There should be clearly visible the site of insertion, so that we can identify any erythema, any leakage at the earliest. The site of insertion should be at the center of the fixation, and transparent fixation should be used for both PICC line and umbilical line. A lot of cases, umbilical line is fixed in a breech manner where it is kept open so that the umbilical cord will heal and dry up quickly. Documentation, we have inserted from a site, we have measured the length, but none of us know where is the tip exactly. That's why after the procedure, doing an X-ray to confirm the position is more important. It does not matter whether you have inserted it the first time or it's the 100th time. X-ray is mandatory for all central line placements to check the tip position, proper tip position. Because a lot of cases are associated with improper position. Like sometimes the umbilical arterial venous catheter goes into the hepatic vein, and there can become hepatic collections or hepatic abscess formations are documented. Similarly, PICC line may go into abdominal wall or to the spinal part. Sometimes it get coiled, and sometimes if the length is not measured properly, it may go into the heart. So pericardial tamponade, pleural effusion, abdominal peritonitis, all these risks are there. So it's better always to confirm the tip position. And it also helps to monitor next time if there is any complication, you can do and check the tip position, whether it is dislocated, whether the position is changed, or central line is migrated. All those things can be documented. So after insertion, it's always advisable to confirm the tip position by X-ray. Here you can see one on the left side, the proper tip position, and then the other side, the length is not measured properly. So it is entered into the heart, then it's going in the pulmonary artery. So this can cause complications. So it should avoid it. So insertion After insertion, the insertion checklist should be followed to prevent our collapse. We are inserted a central line for the benefit of the baby, but we should not give any infection because of our procedure. So strict nursing monitoring is very important in these cases, like hand hygiene is followed or not, aseptic technique is followed or not, proper mask cap is used or not. So central line insertion checklist should be followed to prevent or decrease the chances of collapsing. This is our insertion bundle. Now comes into the maintenance bundle. Maintenance bundle, first thing, daily check for readiness to remove. We should use the central line edge less edge possible. Once our baby is on full feed, once our target is achieved, we should remove the line at the earliest. So daily the question should, is it necessary? Second, whenever we are going to handle the central line, hand hygiene is mandatory, using gloves is mandatory. The aseptic area, sterile area should be prepared. We should use your either sterile cloth or green sheets should be used to handle the line, and it should be covered properly. Check for any redness, any extravasation, any blockage in the line. Whenever we are handling the tip or scrub or changing the tubing, the hub should be scrubbed, properly cleaned, then only it's refixed. Tubing change, IV tubing change, it depends on the unit protocol, but most of the unit, it is followed 24 hourly. We should not continue any tube more than 24 hour because generally we make TPN at 24 hour. Daily TPN are mandatory. So 24-hour changing can be practiced. Some of the unit practice 48 hourly, but it should not be delayed more than 48 hours. Maximum 48 hours, preferably 24 hour, we should change the tubing. The aseptic non-touch technique, the most commonly that we have discussed now just only. Okay, hand hygiene, sterile area preparation, wearing gloves, not touching the key parts like the ports, like the insertion site should be avoided, and repeated handling should be avoided. The bundling of care or bundling of handling is important. If you are going to care the baby now, do all the things at a time. Handle the baby, if your infusion is to be changed, change at the time. Check for any other which can clubbed antibiotic you are going to give that at the same time, so that you will not handle the lines multiple times. Check for any signs of bleeding, redness, or dislodgement. Scrub the hub. It is the most important to prevent the central and associated bloodstream infection. The hub should be scrubbed with alcohol and it should be allowed to dry for 15 to 30 seconds. Then only after that, you should be connecting the new tubing or new medication. The maintenance care bundle, we've taken it from the other hospital and you can use similar care bundles in every hospital. Like whenever the central line is handled, hand hygiene is followed or not, gloves were used or not, hub scrubbing was done or not, caps are uncapped, used, unused caps is there. Then coming to the next. Then is there any number of pricks? Yeah, number of pricks. What is the duration of line? So that we can make that this line is already 7 days old, so we should need to change or we need to shift to other part. That should be documented daily. Flushing, flushing generally at the time of insertion, you may need to flush in cases of umbilical venous catheter or umbilical arterial catheter, or to check the patency or to check the blood flow, backflow is present or not. In cases of PICC line, it should be avoided. PICC lines are very thin, very small caliber and thin. If you are using higher pressure, it can break or it can dislodge inside and it may require surgical intervention. So PICC line, flushing the PICC line should be avoided. But sometimes if there is any blood backflow is there or blockage is there, you may need to flush. And always it is preferred to use a 10 cc syringe or higher volume syringe so that the pressure generation will be less and chances of rupture will be less. Always remember, smaller syringes generate higher pressure. So try to avoid 1 cc use of 1 cc syringes. In neonates, use of central venous catheters like either PICC line or umbilical line, we do not use Haplock because it needs a continuous infusion and the chances of blockage are very high. So Haplock is not preferred. Haplock generally we do in cases of pediatric populations where the line to be used for chemotherapy or to be used for antibiotics. After that, we are not using. So we can Haplock it and keep it for more than 24 hours. Complications. The central line major complications, some of the complications are at the time of insertion, like if our line is not proper placed, it can develop complications. If the line is inserted into PICC line or inserted into heart, it can develop cardiac arrhythmia, pericardial effusions, cardiac tamponade. All these things are insertion related. At the same time, there can be risk of bleeding at the time of insertion if the baby is very preterm, mother has some medications, or there is baby in sepsis where the risk of infection is very high. So chances of bleeding at the time of insertion is very high. After that, the risk of other sepsis. If you are using for 7 to 14 days, the chances of sepsis is there. Using for a longer period, the chances of thrombophlebitis is there, thrombosis is there. It can be prevented by taking proper care like hand hygiene, minimum handling, observe early, quick daily observation for any signs of sepsis, any signs of redness in the skin, so that we can remove the line quickly and take proper steps. Line related complications like catheter migration. If the line is not properly fixed, there can be change in the length. Dislodgement, sometimes if you're not properly fixed, the baby keeps on moving hand or leg, or the line get entangled with the nesting, it can dislodge. Breakage, if you are doing flushing or during the time of removal, the breakage complication most commonly reported during the time of removal, because you do a suturing of umbilical catheter. If you are removing that by using a blade to cut the suture, sometimes the line gets cut and the small parts can enter inside the baby. So this should be handled properly, and this should be taken care meticulously. The next, removal. The same aseptic technique should be followed that we have followed during the time of insertion. Hand hygiene, using gloves, remove the dressing properly. Removal of dressing, you can use that spray. There are certain sprays that makes it easier. The glue becomes soft and makes it easier so that the skin injury will be less. Take one hand at a time to handle the line. Do not touch the surrounding proportionally. Pull it properly. If you are facing any resistance, then gently remove it, or you can do heparinization. In cases of PICC line, some massage over the line track can help in removal of the PICC line. If you're still not sure, it's very much resistance is there, very much resistance is there. Take a opinion, take consultation from other persons like pediatric surgeons. They may help you removing the line. If there is any chances of sepsis or you're suspecting sepsis or thrombophlebitis, better to send the tip culture for microscopy, tip culture and tip microscopy. So these small changes like hand hygiene, daily monitoring, daily readiness for removal, it can have a bigger impact. And these impacts are rewarding, always rewarding, like survival of our smaller preterm babies, better outcome in our NICU. So these small changes should be adopted by everyone and should be taken care during the insertion and care bundle.
Thank you so much for the very insightful discussion and a very knowledgeable session for all of us over here. And according to our agenda, we will further proceed for the Q&A section. Any questions? It's an open forum Q&A. So any questions, anything is there, you can put it in the chat box. My colleague Ipshita is there. She has been monitoring. Some questions has already reached to her. So please share your questions in the Q&A box. And Ipshita, over to you.
Yeah. Hi, good afternoon, sir. Sir, we already have received few questions. So first question is like you said that we can give the chemotherapy through the central line, sir. So preferably, which type of central line we can use to give the chemotherapy to the neonates?
Sorry, madam, not able to hear. Which type of central line is used?
Little bit
To
louder,
give,
Ipshita. Voice was breaking.
yeah. So actually, the chemotherapy we can give through the central line, right, to the neonates. So preferably, which type of central line we can use to give the
Which type of central line?
Okay. Most commonly, the PIC lines are used. Madam, it is very less to use chemotherapy in neonates. Most of the time, it's a pediatric patient. And in pediatric patient, we are definitely going for a central venous catheter or our CVC. In pediatric, though it's a rare, if we are using, we can use a PIC line.
Okay, sir. So after that, we have one more question that you said if we are not flushing or aspirating the PIC line routinely when not in use, so there is any chance to get that clot or blockage?
Yes, that's why we have mentioned that it need PIC lines. There is chances of clotting is there. That's why the minimum flow rate is 1 ml per hour. We are not blocking it. We are not stopping the infusion. PIC lines, it needs a continuous infusion so that it will not be clogged or so that there will not be any blood clot formation. The central venous catheter, we have discussed in that types also. The central venous catheter, it can be blocked. Preferably, PIC lines should not be blocked. In case of neonates, we are not doing blocking, and continuous infusion should be there.
Okay, sir. So we have few more questions also. So when inserting the PIC line, which hand is preferred, left or right, sir?
There is no difference in left hand or right hand. The length will be same if you are measuring. So nothing. Ultimately, both are going to get inserted in the superior vena cava. Our target is to reach there only. So hand difference is not there. Whichever you are getting a proper vein, proper insertion point, you can go for that.
Okay. And sir, our next question is how frequently we should flush the with the hip lock?
There is no need of flushing a PIC line or umbilical venous catheter. These two lines, there should be a continuous infusion. But in cases of central venous catheter, if you are not using for more than 24 hours, just block it and we can use keep it there. We can use it after 24 hours or 48 hours. So before the next use, you can do again flush it. For 24 to 48 hours, there is no need to flush again. 48 hours, you can do the flushing.
Okay. Another question is there that is tip culture is advisable or not?
If you are suspecting any thrombophlebitis or sepsis, you can go for a tip culture. In neonates, less likely, it's not going to benefit much. But in pediatric patients, definitely it's going to help you.
Okay, okay, sir. Another question is, do we have any checklist for neonates especially?
Checklist, insertion checklist and maintenance checklist are there. We are also following a checklist here in our center. I will ask Arya madam to share that. The checklists are very simple, like the one we have shown in our slide also, like insertion checklist, whether hand hygiene is followed or not, gloves were wear or not, cap mask is used or not, sterile area is maintained or not, how many pricks we have taken after insertion, do we have documented it? That's simple checklist. Same during the maintenance part, you can make your own checklist like hand hygiene, gloves, readiness is checked or not. Is there any redness? Is there any leaking? Yes or no, we can do that and you can mention it.
Yeah, so is there any difference between adult checklist and neonatal checklist? Like it was shown that was adult one.
Yes, madam. But central line checklist, there is not much difference in the checklist part. Heparinization part is there. Heparinization is generally not used in neonates, so that is the only difference.
Okay, okay, sir. So yeah, this is what we have received the question. And so another question we have that is which CVAD is best for neonates?
It depends on your requirement. Suppose My baby is 1.5 kg or 1.6 kg, bigger baby. I am taking the baby into NICU, and I expect the baby will be on full feeds by 5-6 days. So in that case, I will prefer a umbilical line so that I can use for 7 days and my baby will come into full feeds. If it is a very preterm baby, I am expecting that baby will take some 2 weeks or 3 weeks time, or the baby will require a longer duration. Like our case discussed here, it's a smaller baby. In that condition, first I may go with a umbilical line for emergency management, for the emergency treatment, and later on I can go to a PIC line. Similarly, if a larger baby, we are planning for any surgery, abdominal surgery is planned. That condition, I can't use the umbilical line, so I will go for a PIC line. So depending on the condition, we have to choose the central line part. There is no such specific which is best.
Okay, sir. Thank you. Another person is asking that can I get insertion and maintenance bundle for the pediatric? Yeah.
Yes, madam, we can share that. Insertion and maintenance bundle of our pediatric population is there, and we can share that.
Okay, sir. Yeah. So this is what, sir. Till here we have received this much question only. So if anyone is having any other question, you can share them in the chat box.
Right. We've got a lot of questions.
Yeah, another question we have received that is no backflow, only forward flow is there. So line is indicated to use or what?
In cases of if your line is not at the proper position, then the backflow will be very less likely. At the time of insertion, if you are not getting a backward flow, then don't fix it. Go for an X-ray, check the tip position, then only fix it. After some days, if you are using a PIC line or umbilical venous catheter and you are not able to get a backward flow, in that condition you can use, but with monitoring. But at the time of insertion, if you are not getting a free backward flow, then it should not be used.
Okay, sir. Thank you.
Early sign of CLAPSI infection in neonates. CLAPSI, it's a easy term to say, but difficult to level. Because it comes, we level CLAPSI if there is a central line and the baby it is used for 2 days or removed just 24 hours before. But at the same time, we have to rule out other causes of infection or other causes of bloodstream positivity. Suppose I have used a central line and the baby developed NEC. Yeah. The blood culture will be positive. But in that condition, we cannot level it that is because of the central line. Similarly, the baby has pneumonia or baby has meningitis, I used a central line for antibiotic. So in that condition, we cannot say it is because of central line. So CLAPSI, that it comes with the terms and condition that other causes of bloodstream infection is ruled out. And in Indian scenario, I'm clearly saying it is very difficult to rule out other causes. You cannot take a bronchoalveolar lavage culture for all baby. You cannot rule out other site of infection for all babies. So CLAPSI is a difficult term, but if other causes are ruled out, then definitely it's a CLAPSI. And earlier signs like bloodstream infection is positive, then there may be a rise in CRP, drop in thrombocyte platelet count, thrombocytopenia will be there, or most commonly in neonates, there will be decrease in the total leukocyte count.
Okay, sir. Thank you, sir. We have another question. That is,
flushing is not recommended. Clearly, flushing is not recommended in neonates. It's a continuous infusion is better. Should keep a continuous infusion of at least 1 ml per hour. If you are using a PIC line, try to avoid only heparinization. We add heparin in TPN. So the line patency will be maintained and directly total parenteral nutrition, or heparinized saline is used in cases of umbilical arterial line, where we are doing a continuous monitoring of blood pressure. In that condition only we are using it.
Okay, sir. Thank you. Yes, we have another
In cases
question.
of catheter occlusion, try to flush with normal saline in using a larger bore syringe, like 10 cc syringe. You can try that. But if you are getting very much resistance or not able to flush properly, better to remove it. Because putting a PIC line will be less tiresome or less costing to you than developing a catheter breakage or going for a surgery for that.
Okay, sir. Thank you. So if anyone is having any other question, you can drop it in the chat box.
Right. So it's for the participant a very important announcement. There is a feedback link which has been shared by Shinoj in the chat box. Please, before leaving the meeting, it is mandatory for all of us to please fill in the feedback form for the next. It's important for, as it's the first session of IV Talks. So for improving on the further sessions, for your feedbacks, everything is very much important. So please fill in the feedback forms. And there is another question in there, sir. Can we get insertion and maintenance
No,
bundle
madam,
for
please,
pediatrics?
we will provide that. We will share. Arya madam will share this insertion and maintenance bundle with all the participants.
Done. So with this, I think it's time to wind up because we have already touched 14:28. So we may have to skip our quiz for this IV Talks. It's been a long session and very engaging session from your side, sir. We couldn't have time for the quiz in that case.
No, very much. The participants are also very active. They had a lot of query and a very good session. We had a lot of discussion.
Right.
Thank you.
Thank you.
Thank
Thank
you,
you so
Pooja.
much, sir. Thank you, ma'am.
Thank
Thank
you,
you,
sir.
Arya, ma'am. Thank you,
Thank you so much.
Neha.
Thank you
Thank
so
you
much,
each
sir.
one of you for joining
Right.
today. And I'm thankful to Binu Madam and Polymed for this session. And thank you, Gowda sir, for the really wonderful session. I was with sir and I could see the involvement of all participants. Thank you, participant. Because of you, we got it really interactive session. Thank you so much for your participation. Looking forward to it. Thank you, Durga, and thank you everyone who has joined. Thank you. Thank you.
Thank you, Binu ma'am. Thanks, Ipshita
Thank you,
and
Binu
Shinoj.
ma'am, if you are there. I thought ma'am is not there. Thank you, Binu ma'am.
Yeah.
Thank you very much. Thank you
Bye.
all.
So we'll leave.
Thank you.
Take care, everyone. Have a great day.
Thank you, ma'am. Thank you.
Thank you so much.
sir.
Thank you, ma'am.